And it's great to see so many people here at Westmead Institute for Medical Research for our Science Week. My name is Diane Humphreys, and I'd like to start by acknowledging the Darug people, who are the traditional custodians of the lands and waterways here in Westmead. I also pay my respects to elders past, present and emerging, and celebrate their ongoing culture and connection to this land and water. I also welcome and acknowledge the Aboriginal and Torres Strait Islander people we have with us here today. I'd like to kick off with a short video about WIMR and what we do in Western Sydney and globally.
Greater Western Sydney's ascension to prominence in the Sydney Basin is underscored by a unique convergence of factors. With more than 160 different nationalities and the most extensive urban Aboriginal and Torres Strait Islander population in Australia, it's home to 2.5 million people. It contributes to half the New South Wales economy, with notable infrastructure investments, including the forthcoming Western Sydney International Airport and improved transit networks set to further increase its significance and influence. As a result, it's not surprising that the Westmead Health Precinct is home to two of the largest teaching hospitals in the state, the CSIRO and Medical Research Institutes. But at its heart and driving internationally recognised research is the Westmead Institute for Medical Research, better known as WIMR. One of the largest medical research institutes in Australia, it has more than 400 staff and students across 11 centres. Closely affiliated with the oldest university in Australia, the University of Sydney, and Westmead Hospital, many of WIMR's scientists are also clinicians working in the Westmead Adult and Children's Hospitals, along with researchers across many disciplines. This means knowledge gained in the hospitals can be translated to the laboratory, offering a unique bench to bedside and back approach. This affords WIMR a translational advantage to precision medicine, forging breakthroughs in areas such as mental health, ovarian and breast cancer, heart failure, and antibiotic resistance, to name just a few. All of this, along with the diverse community it serves, makes the Westmead Institute for Medical Research one of the most innovative and groundbreaking research facilities in the world.
The structure we have here is that we've got 5 major research areas. Infection and immunity, so that includes HIV, COVID, multiple sclerosis and antibiotic resistance. We've got cancer, which on the 7th floor, the whole 7th floor here is devoted to cancer research. Liver and metabolic, that includes hepatitis, diabetes and obesity. Then we have neuroscience and vision, so that's brain function, mental health and vision disorders. And finally, cardiorespiratory, so that's sleep disorders that you'll hear about today, asthma, as well as heart damage. What we're all about at WIMR is precision medicine, and you may or may not have heard of that term. So traditionally, when patients are diagnosed, they were given a blanket treatment, a standard treatment that everyone got. At WIMR now and in the future, we're all about precision medicine. So that's taking the individual and their diagnosis, looking at their genetics, their environment and lifestyle, and then using data analysis to come up with personalised individual treatment. And that's far more effective and gain improved outcomes and also far less side effects.
So today we're very lucky for our second speaker. We have our Associate Professor, Kristina Kairaitis. Kristina completed her medical degree and trained at St Vincent's Hospital. She did her physician's training at Concord Hospital and then her advanced training in respiratory and sleep medicine right here at Westmead Hospital. After her specialist training, Kristina gained her PhD in upper airway physiology. More recently, she has commenced research into the interactions between sleep disorders and cancer. She continues to be involved in clinical management of patients with respiratory and sleep disorders at the Westmead Hospital next door, and she's also involved in teaching medical students from the University of Sydney. Her talk today is entitled Cancer Patients and Sleep. Please welcome Dr. Kristina Kairaitis.
Thanks. Thanks. It's really nice to see you all. Thanks for coming. Hopefully I'm going to entertain you a bit, but hopefully you might learn something and maybe use it in your daily life. I'd like to start by acknowledging the Darug people who are the traditional custodians of the lands and waterways in Westmead and paying my respects to elders past, present and emerging. So my talk today, I'm going to give you a brief chat about why we sleep and what are the functions of sleep. We're going to talk about sleep and in cancer patients and sleep disorders in cancer patients. And then some possible interactions between sleep disorders and cancer, with a focus on breast and endometrial cancer and melanoma, and then the kind of stuff that I'm looking at the moment, what my current directions are. So we might start with a question about why we sleep, and I suspect most of you have never thought about it, except that you sleep because you're tired. And in fact, that's not the only reason you sleep, although it might be one of the reasons. And this sculpture is one of my favourite artists. It's a guy called Constantine Brancusi, and this is a sleeping muse. So first of all, every animal, every organism has some evidence of wake-sleep states. So that makes everybody think, well, if every organism has it, it has to have some fundamental function. When you look at how long animals sleep, it's actually really variable. And there are some animals, these are carnivores on the top, omnivores in the middle, and herbivores on the bottom, and they've been plotted against their weight. So there are some animals who sleep for 20 hours a day. They're not party animals. There are some animals who sleep for as little as 2 hours a day, and you can see they're African elephants, for instance. The heavier you are, if you're a herbivore, the shorter you have to sleep. And that's probably because if you're a really heavy herbivore, you have to spend a lot of time eating. There's another stage of sleep which is also very variable. So you may have heard of rapid eye movement sleep. Rapid eye movement sleep is also variable amongst animals, and there are some animals that have very little rapid eye movement sleep and some that have lots of rapid eye movement sleep. At the moment, we don't know why you need rapid eye movement sleep, and we don't really completely understand the functions of sleep, but I've got to talk to you about it. Human beings, they put 7 hours here. That's actually gender variable. So women need 8 hours sleep probably, and men need about 7, possibly because of hormonal requirements. And we have about 2 hours a day of rapid eye movement sleep. So why do we sleep? So it's a really dangerous thing to do. If you're living somewhere where there are tigers and lions and you go to sleep, you could easily be eaten. So there must be a really good reason that we do it. The early theories about sleep were that it was about conserving energy, that you couldn't eat enough to keep yourself awake. And certainly the elephant might make you think that might be true. But this is not the only reason. There are peripheral functions, so functions of your organs that are definitely impacted if you don't sleep. It's really important that for metabolic function, if you don't sleep enough, it upsets your glucose control. It also upsets your appetite, which is probably why there are so many, everybody craves hot chips when you wake up, when you haven't had enough sleep, and why there are so many can't think of the word at the moment. Anyway, it also is important for your cardiovascular system and immune function. And people, a lot of patients I see with pneumonia, for instance, have just not had enough sleep before they get the pneumonia. It's also got a whole lot of neurological functions which we're starting to appreciate. There's this new system that's recently been described, which is essentially brainwashing, where we clear metabolites from our brain during sleep, and that happens in a particular stage of sleep called slow wave sleep. There's also evidence that all the things that you do during the day, which are generating synapses in your brain, get undone. So that way you don't have to remember what you had for breakfast 20 years ago, which is really important when you think about it, and that leaves room for other things to happen. And probably most importantly for you guys, it's really important if you're going to learn something that you get a good night's sleep. So the things that you learn at school during the day, or even listening to me today perhaps, if you get a good night's sleep you might remember them, but you won't if you don't. So there are actually medical conditions in sleep and what we call sleep disorders. Some of them are more important than others, some of them have health consequences. There are sleep-related breathing disorders, which I spend a lot of my day and time treating. There are insomnia. Now, insomnia has a variety of causes. There are disorders of hypersomnolence. So there are some people who literally cannot regulate their sleep, who fall asleep when they don't mean to. They're incredibly rare. There are disorders of your interactions with the circadian rhythm. So we'll talk briefly about those in a minute. And there are also disorders which are parasomnias. So some of you might be sleepwalkers or sleep talkers. They're parasomnias. They're not particularly significant. There are some parasomnias that are more significant. And there are also sleep-related movement disorders. So some people get neurological disorders that only occur during the night in sleep. In terms of the interactions with cancer, the only ones that we're going to briefly talk about are the breathing disorders, insomnia and circadian rhythm sleep-wake disorders. And these are the classifications from the International Classification of Sleep Disorders. So we started, and I will show you why we started asking this question, just asking the basic question, do cancer patients have sleep-related symptoms? And this is one of the publications that we've had and what we went to sleep clinics and we asked specific questions of women with breast cancer, women with history of breast cancer, a history of endometrial cancer, and then patients who've had a history of melanoma. And the questionnaires that we asked are listed here. So there are questions about sleepiness. Does their sleepiness or your sleep problems impact on your life? What's the severity of your insomnia symptoms? How did you describe your sleep, which is sleep quality? And then some symptoms related to obstructive sleep apnea, which I'm going to talk about. And we broke those questions up and put them into what's called a cluster. So this is fancy statistics that I had to ask someone else to do. And you can find 4 basic clusters of sleep symptoms in cancer patients. We called those clusters patients who were minimally symptomatic, so they didn't have any real sleep symptoms. Those where insomnia was the big issue. Those who had what we would think of as classic sleep apnea kind of symptoms. And those who had symptoms where their sleep symptoms were really impacting on their day. And if you look at the difference in the different cancer types, you can see the endometrial cancer patients, they have any kind of symptom. They're not really particularly clustered. But breast cancer patients were more likely to have insomnia kind of symptoms and also dysfunction. And the melanomas were actually more likely to be minimally symptomatic or have sleep apnea kind of symptoms. So cancer patients do have sleep symptoms. There are symptoms of sleep disorders that are present in patients with cancer, and they probably vary between cancer types. And I've actually put this photo up here because it's about varying with cancer types. This is sperm whales sleeping, and they apparently sleep in the vertical position, which I thought was pretty cool. So, does it matter? Who cares? does having a sleep disorder matter if you have cancer? And is there any interaction between having a sleep disorder and your cancer? Does it cause you to have cancer? Does it make your cancer worse? There is actually some evidence for that, and that's what we're going to talk about. So we're going to start with obstructive sleep apnea, which is a disease that I treat. Maybe some of your fathers, most likely, have it. So obstructive sleep apnea is a disease of the upper airway. These are two MRIs through the back of the throat of this is a 35-year-old man and a 45-year-old man. This man has obstructive sleep apnea, this man doesn't. And you can actually see the difference. I've highlighted their airways, the back of their throat. And you can see that the 45-year-old man has a narrow throat. We can't work out, we don't do MRIs on people routinely, and we can't work out just from asking people questions about whether or not they have sleep apnea. To work out whether someone has sleep apnea, you actually have to do a sleep study. You can do these at home now, and there are a whole lot of work to doing minimally invasive ones. But from a sleep study, you get a whole lot of physiological signals that you can assess. This top one here is about so this is 8 hours in bed. The top one here shows you the kind of sleep this person had. So the red are above the line here is rapid eye movement sleep, and the blue and yellow and green are no rapid eye movement sleep. Down here you can see where we've scored the kinds of apneas, obstructive, hypopneas that they've had, so airway closures. And this is the oxygen saturation that's a consequence of these airway closures, of this failure to breathe. From these sleep studies, we get two indexes. We get one of airway obstruction, what we call the apnea-hypopnea index, and one of a description of hypoxia. So you can describe hypoxia in lots of different ways, low oxygen levels in lots of different ways. You can talk about how many times it happens per hour. You can talk about how low it goes, or you can say how long do they have a low oxygen saturation under 90%. There are some epidemiological studies. So epidemiology studies are where they've taken a population, they've done sleep studies on these people, and this is a study in America, and there's studies in Western Australia. And they've gone forward 20 years in both cases here, this one's 25, and they've said, well, is there any relationship between how severe your sleep apnea is and your likelihood of dying from cancer or your likelihood of getting cancer? And both the American study and the Australian study suggest that if you have severe sleep apnea, and this is untreated, clearly we would hope that treatment would modify this, your chances of dying of cancer are actually higher, and that also came out. And your chances, in the Australian study, your chances of getting cancer were slightly higher too. It's probably related, more likely, to the oxygen rather than the disruption you're getting from waking up all the time, keeping your airway open. So you can look at oxygen. This is the apnea-hypopnea index. As I said, that's a measure of how often you're closing your airway. And if you look at this is cancer incidence, that's not particularly different between the different kinds of airway obstruction. But if you look at the oxygen, and this measure here is how long did you have a very low oxygen saturation during the night while you're asleep, you can see your cancer incidence is much higher over, this is 96 months, if you spent 12% of the time with a very low oxygen. So we actually then went and looked and did sleep studies in our two women with cancer. And so we've done it in patients with breast cancer and women with endometrial cancer. The breast cancer patients are about 12 months post breast cancer, so they've had breast cancer, we're looking backwards. And the endometrial cancer patients are at least 3 months after they've had surgery for their endometrial cancer. So it's that's cancer of the uterus for the people in the room that have no idea what I'm talking about. If you look at the obstructive index here, there's 15, anything over 30 is severe. They're probably, and this is the respiratory disturbance, but just focusing on this one, you can see that there is more quite a lot of them have what we would call at least moderate to severe obstructive sleep apnea. And in fact, when you go and look at what's reported for the population, there's slightly more in this group than you would expect for an age and BMI match. Now, that might be because age and BMI match women, so age and obesity match women. That might be because partly uterine cancer is actually linked to obesity, so the more obese you are, the more likely you are to get it. But so is postmenopausal breast cancer. So that might be why. It just might be that they've got the same risk factors for these diseases. We then ask the question, well, can you find any evidence of a worse kind of cancer in the people who had sleep apnea? So this is the grade of cancer. The higher grades, so grade 1, 2 and 3, the more severe cancers are grade 3, the less severe are grade 1. And the answer was, when you looked at oxygen, this is oxygen metric, this is how long did you spend with an oxygen, how many times an hour does your oxygen desaturate by more than 3%, and this is the obstructive metric. There isn't any evidence that there's any relationship at all to the severity of your sleep apnea and the severity of a cancer. So maybe it's just that they have risk factors that are the same. There's another publication by some Spaniards who actually show the same thing in breast cancer, that it's not related, but they probably have coexisting disease. However, the Spanish have found that there is a relationship between the severity of your sleep apnea, and this is a measure of how aggressive your melanoma is. The Breslov index is a really simple index where you look at a melanoma under a microscope and you ask the question, how deep is it? And the deeper it is, obviously, the worse it is. And there is a relationship between the severity of both your sleep apnea and how much oxygen you have and how bad how deep your melanoma is. And that's kind of not surprising because there's really good evidence in animals. So if you they take nude mice and they give them melanomas and then they expose them to oxygen fluctuations that are equivalent to the oxygen fluctuations that you would get in obstructive sleep apnea, and essentially measure what happens to the tumour over time. And you can see that in those which are exposed to those oxygen fluctuations, the tumour grows a whole lot faster. And at the end of 2 weeks, it weighs a whole lot more than it did if you didn't have that exposure. So it's kind of not surprising there might be a relationship between oxygen fluctuations and melanoma. Even more evidence, this is the same group. They had 443 patients with melanoma. And those with sleep apnea, they tried to treat. Some people will accept treatment and some people won't. It's not easy to treat. And you can see that if you have mild or moderate sleep apnea or severe sleep apnea and on treatment, which is this blue line here, you don't have a melanoma recurrence or you don't develop melanoma elsewhere and you're not going to die. Whereas if you have severe sleep apnea and you don't treat your melanoma, this is what happens. So there's some evidence that maybe there is an interaction between obstructive sleep apnea and the oxygen levels and melanoma. It's not clear, though, for the breast and endometrial cancers. We did also look, and we have also looked to see what happens when we treat our breast cancer patients and our endometrial cancer patients and the melanoma patients, and we've just looked at symptoms. So this is what we call the PSCI, which is the Pittsburgh Sleep Quality Index. The blue line here, anything below there, those people tell you have good sleep. And this is baseline before we treated them. These are people who didn't need CPAP, and you can see that there's really no change over the time that we followed them, which was up to 3 years. That their sleep symptoms, some of them got better, some of them got worse, but essentially there's no significant difference between the two. But in the people that we managed to get onto CPAP therapy, which is the treatment for sleep apnea, and we managed to maintain on CPAP treatment, they actually get an improvement in sleep quality. Thank goodness. So, when you look at a particular sleep disorder, which is obstructive sleep apnea and cancer, there's an increase, mortality and incidence of cancer. It's likely related to oxygen fluctuations. Treating it does improve the outcomes for some cancers and also cancer symptoms. What about other sleep disorders? Sorry, this is a chameleon sleeping on a leaf. Isn't that cute? All right, so this is a study from it's about 8 to 10 years before, over 8 to 10 years, in a group of women who had metastatic breast cancer. So they've got breast cancer not just in their breast, but everywhere in their body. And they've got two groups here. So these are women who can sleep 85% of the time that they're in bed, and these are women who can't sleep 85% of the time in your bed. And you can see that there is a very big difference in your chances of dying depending on your sleep efficiency. So those with really good sleep efficiency had a lower chance of dying than those with poor sleep efficiency. And it's actually quite a striking difference. We've looked at something called sleep regularity. So I'm going to just describe sleep regularity because it's a reasonably important concept. It's about what the chances of you being awake or asleep at exactly the same time every day are. So if you go to bed at 10 o'clock every single day and you get up at 6 o'clock every single morning, you'll have a sleep regularity of 100. Nobody has that, right? None of us do. But if you never, ever, 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 ever go to sleep and wake at the same time, you've got a sleep regularity of 0. So essentially, it's a continuous scale that describes the kind of probability of you being awake or asleep. And what we did, and to get that measurement, what you do is an actigraphy. All of you are wearing, or some of you are wearing actigraphs on your hand right now. So they're things that measure your motion during the day. When you're awake, you're moving. When you're asleep, you're not. If you record that for a couple of weeks, you can actually take that recording and generate a sleep regularity index. We looked at the sleep regularity of our breast cancer patients and our uterine cancer patients and our melanoma patients. And you can see that, that they have what you expect. They've got reasonable sleep regularity. Mine's probably about 80% too. There are some days I do go out at night. I'm not completely boring. And but there are some that have really poor sleep regularity. And then what we did was ask ourselves the question of, well, does that relate to anything? Does it relate to any symptoms? And the answer is it's a better predictor of your quality of life than any other sleep metric. So it's a better predictor of your quality of life than how long you sleep, how long you wake, how many times you wake up, how long it takes you to get to sleep. The other predictor, and this is quite worrying for me, of having good quality of life was being a boy, but anyway. More recently, and this is not my work, but this is the people that I collaborated with to get that data, they took some data from the UK Biobank. So this is 60,000 people where they looked at the sleep regularity and followed what happens. So the sleep regularity measurements are all made here, and then they followed what happens over 8 years to those people. And in news that should terrify those who go clubbing, those with very poor sleep regularity were less likely to die. And in fact, interestingly, this mortality is particularly related to predicting your cancer death. This cancer death is actually the one that came out as the highest. There's also some data about sleep regularity in your cardiometabolic health. It's actually a better predictor of your cardiometabolic health than other metrics of sleep. So, and I've put the dolphins up here, and these are sleeping dolphins, even though you probably can't tell. And that's because dolphins go to sleep half the brain at a time so they don't drown. So we went and looked at breast cancer patients, and that's because I've shown you that they're the ones that have sleep symptoms. They're the ones that are really, the sleep is impacting on their lives, they're feeling unwell, they notice it. So 30 to 60 95% of women with breast cancer who've had breast cancer treatment will tell you they have poor sleep. They have difficulty falling asleep, they have difficulty maintaining sleep, and they have difficulty with restorative sleep. And that's actually, as I said, linked to your reduced quality of life and survival. And this is evidence, again, of their sleep quality. And you can see that the breast cancer patients stand out compared to the other cancers. They have really poor sleep quality. These patients don't have breast cancer. They've just had breast cancer 12 months ago or more. So why might you have poor sleep? So if you've got a history of cancer, then you could lie awake worrying about whether it would come back. That would probably give you poor sleep. It might be something to do with the kind of treatment that we give these women. So a lot of them get hormone blockers. Every woman in this room is postmenopausal will tell you losing estrogen is awful because it disrupts your sleep. It might be because you have other comorbidities, like pain, for instance, from some of your therapy. It might be some other psychological factor that's affecting it. But the one we were interested in was circadian rhythms disruption. I don't know how much of you know about circadian rhythms, but we're going to talk about them briefly. So, how do we sleep? This is actually the processes that underlie sleep. So, the description of sleep relies on what's called it's called the two-phase model. So, there are two processes. There's what we call process S and process C. So, you wake up, the longer you stay awake, the more you need to sleep. That's what process S is. And then when you go to sleep, that sleep drive drops off. In addition to that, we have our circadian rhythms. So if you wake up and you're exposed to sunlight in the morning, what happens is there's a central circadian rhythm that will actually keep you asleep during the night. So that central circadian rhythm is really important. We've all got these clocks in our head. We've got clocks everywhere else too. So the clock in our head is set every day, and it's set by exposure to sunlight, and it times then all the circadian rhythms and all the other cells in your body. So every single protein in your body is expressed in the circadian rhythm. And a lot of disease is probably related, and this is not, it's not clear, but I'm starting to believe that it's got to do with circadian dyssynchrony. So the central clock is out of sync with the peripheral clocks, or the peripheral clocks are out of sync with the central clocks. That timing stuff's really critical. So there are a lot of processes in your body that are happening every process in your body is circadian. So how do we measure circadian rhythms? So circadian rhythms are hard to measure, would you believe? Don't know why. It's one of the questions I've got. It's one of the questions we're hoping to work out, because I think if we can work out why, we might, obviously we'll be able to make their lives better, but also we might actually understand some more fundamental things about why people get breast cancer. So why might their circadian rhythms be abnormal in women with breast cancer? It might in fact predate their breast cancer. It might be a risk for breast cancer. We know that if you're a shift worker, a night shift worker in particular, that increases your risk of breast cancer. It might be the individual sensitivity to light. So I've told you that your circadian rhythms are actually kicked in by exposure to light in the morning. If you're exposed to light at night, that suppresses that circadian rhythm. And that might be a bad thing if you're a woman who's predisposed to breast cancer. It might be the kind of light that you're exposed to. You may not have sufficient bright light to make your melatonin big enough, or it might be in fact related to the presence of cancer. And there is some animal data that shows that having a cancer changes the circadian rhythm, and even when you take it out, the circadian rhythms don't go back to normal. So this is one of the things that I'm hoping sometime to investigate. So in summary, sleep symptoms vary between different cancer types, as I showed you. Obstructive sleep apnea, and specifically fluctuating oxygen levels, are associated with an increased incidence and death from cancer. And if you treat that obstructive sleep apnea, you can improve both sleep quality but also melanoma mortality. That irregular sleep is associated with an increased mortality and poor quality of life in cancer patients, but the mechanism of irregular and poor sleep is uncertain. So I think investigating sleep in patients with cancer and the interaction between sleep disorders and cancer actually represents an opportunity to improve quality of life and improve longer-term cancer outcomes. And I just want to thank all the people that I've worked with on this, of which there's a few thousand. None of this is just me. I'm just the person standing up waving the microphone, and also the people who've supported it financially. Thank you.
You mentioned earlier in your slides that there's a correlation between obesity, well, obviously with OSA, and like specific types of cancer. How has the development of GLP-1s like Ozempic affected that, and have we done any studies on that?
No, and they haven't been around for long enough, really, for that kind of... Because if you think about those associations, you need 10 years to work that one out.
Probably. Sorry, I'm a very bad sleeper. Yeah. And,
Have I scared you? I'm so sorry.
I know a stroke 5 years ago and a heart attack 10 years ago. So, but the question I want to ask you is about, do you recommend us to have sometime I need to sleeping tablets?
So the problem with most sleeping tablets is they're short term. We haven't really got any longer term sleeping tablets. Most of them are short term, and if you are really only recommended for short periods of time, we don't recommend them. There are some newer ones which actually work specifically on orexin, and they are possibly better, but they're incredibly expensive. And there isn't any long-term data on those. So no, I don't go straight to sleeping tablets. That's the first thing I do.
I've got a two-part question. So one was, in one of the slides you had the different causes for poor sleep. So some of them are like very sleep related and some were of course the condition related. Is there a difference in like that prevalence? Like how many do you get that's more related to the physiology with disease than have a poor?
Yeah, I don't know the answer to that question. I mean, it's a good question. It's one that's worth asking. I mean, the kind of people I see usually have multifactorial reasons for poor sleep. Very few people just have one reason for poor sleep. A lot of them, it's the kind of behaviour they have. If you think about, I usually use that two-phase model that I was talking about. So, people who sit inside in the dark all day and watch Netflix are going to have poor sleep, right? Inevitably, because they aren't exposing themselves properly to the nice bright light. They're not exercising. So lots of people have more than one reason. People who try to sleep at midday, they're going to have some quality sleep.
And second question, what has been the reception like for circadian rhythm related treatment? So have you suggested light therapy to people and have them be receptive to that?
Yeah, so light therapy hasn't quite taken off, right? Partly because it's really difficult to use. It is really, it's used in some parts of the world. Seasonally acquired depression is a real problem. So there are people who do get depression as a consequence of living in darkness, which, the far North Pole people do. And they do treat those people with light. And once upon a time, that used to mean sitting in front of a 2,000 lux box for 2 hours in the morning. Now there are glasses that you can use, which actually just expose your light, but they're still cumbersome. And there's a lot of, one of my collaborators actually thinks that depressions, and I suspect he's right, a lot of the mood disorders are probably circadian related. And he essentially, depression's waking up at 4 a.m. Who's happy then? So he's actually pushing towards circadian stuff. It's still really early in the sort of timing of circadian medicine. And I suspect that it's going to be the future. There are already, I went to a presentation last year where they were talking about medications that manipulate your circadian rhythm, which treat blood pressure, for instance, so I think there is going to be a future for circadian rhythms and circadian medicine. And I think already even in cancer treatments, they're starting to talk about, the timing of chemotherapy being critical, because we know that circadian rhythms are happening in the proteins in the tumours. But it's very early days.
One more, and that is to do with endogenous melatonin.
Yeah.
And how that have affected that thought that has been.
Yeah, so melatonin's not a sleeping drug, right? It does have some sedative effects, but it's a very low sedative effect. And the answer, sure, is that we don't know. I mean, obviously, those women, you would think the answer might be to give them melatonin, the ones that I was showing you. And I'd like to try that. There are people who've tried it. It doesn't work particularly well. That might be because we're giving it to the wrong people, we're giving it at the wrong time, we're not giving it the wrong dose. It's all really early in that kind of knowledge.
How would travelling a lot affect your circadian?
Yeah, completely stuffs you out, right? Yeah, so jet lag's a real thing, and I'm sure a lot of you have experienced it, that feeling of feeling tired at the wrong times, hungry at the wrong times. That's because your central clocks and your peripheral clocks are out of sync. As I said to you, people who are jet lagged all the time, so people who work night shift, which is essentially a chronic jet lag, that they do have very poor cardiometabolic health, right? Those people are more likely to get diabetes, obesity, heart disease. And that's one of the reasons why there's a lot of work now starting to happen around this, because I work in a hospital that is open 24 hours, and we need people to be able to work 24 hours a day, but we don't want that to be at the expense of killing them. And cancer is also related to that cardiac dysynchrony. The reasons for it aren't clear. One of my master's students looked at whether it was light at night exposure, and at the moment that's one of the hypotheses, that being exposed to light at night, which will suppress your central circadian rhythms, might be the reason, but it's not clear at this point in time.
Is that like artificial lights, not just sunlight?
Yeah, so there's a huge variation in people's responsiveness to light. And this you probably know too. I know that when I travel with my husband, his circadian rhythm clicks around much quicker than mine. There is individual variation. So there was a lovely study a few years ago where they looked at how much light it takes to suppress that melatonin response in a group of young, healthy people. And the answer was, it was anything from 10 lux. So 1 lux is 1 foot away from 1 candle. That's how dim it is. It's really, really dim. So 10 lux is 10 candles. It's not very bright. So some people it took 10 lux, some people it takes 400 lux, and some people you just don't. They don't respond to light. There's also some really interesting stuff about being blind. I didn't tell you this particular. So there are differences in, as I said, breast cancer patients. We know that's related to shift work. If you take a group of blind women and you say half of them can, and not all people who are blind can't perceive light. And you look at the risks for breast cancer between the women that can perceive light and the women who can't perceive light. Not being able to perceive light actually protects you from breast cancer. It's not going to take off as a preventative treatment, but...
I'll actually ask one. You said it's good to go to bed and wake up the same times. What if you're going to bed at midnight or 1 o'clock every day?
Yeah, so it's fine if you're doing it at the same time. Yeah. There's no rule that says it has to be at 10 o'clock and you have to get up at 6. There's a rule that says you need to go to bed at the same time every day and get up at the same time every day, and that you should at least get 6 hours sleep.
I'm also someone who works night shift sometimes. And I was already, as a night shift worker, do you have any tips about what we can do to help look after our sleep when it's, it's part of our work?
I've worked night shifts too, know what it's like. So you need a dark, quiet room. You need to try and avoid light to help yourself go to sleep at night. But you won't, there's a lot of work around what's the ideal kind of timing for shifts, and a lot of industrial law that will probably get changed around making sure that the kind of shifts that people work are right for aren't going to disrupt them too much. But yeah, I haven't got my real shifts, sorry.
I was curious, how likely is that regulation going to be rolled out? Or
Yeah, it's very early days. The answer is it's not. It's still a research tool. It shouldn't be though. It should be something that because everybody's got an Apple Watch. It shouldn't be. Certainly, I know that the Brain and Mind here are using looking at sleep regularity in a lot of their patients, but it's hard to fix because there is a behavioural component in some people.
one other question, because you mentioned about when you were testing, I believe, breast cancer patients about cleaning the saliva.
Yeah.
So would they sit in a room for like 5 hours?
Yes.
And then wait, and then they will go to sleep, and then you wake them up, and then kind of the saliva again at the end of this.
Yeah, so we don't get them to spit in a jar. It's okay. we essentially, they suck a cotton pad, and they do it every hour, but you have to be, the outputs from your central clock are affected by a whole lot of things, just moving. So what we do is sit them in a bed. They are allowed to watch Netflix. But that's about it. And the television's quite dim, but that's really all they're allowed to do. Some of us think it's great. It's a holiday from...
Thank you.
In the last session, someone asked Ruby about her path into research. I'm sure a lot of people here would love to hear, Kristina, how you got into research and your career path after school.
Right. I used to catch a bus with you guys. I went to Roost. I'm the first group of girls that went through from year 7. Used to be a boys' school, and you probably didn't know that. And I had great teaching as a consequence. I was still in the days when it was undergraduate medicine, but I finished school at 17 and got into undergraduate medicine. But when I got in, they said, we have this other degree called science medicine. Would you like to do it? And I actually had always wanted to do, I couldn't decide what I wanted to do, let's face it. None of us really know what we want to do. I still don't. But I decided that I would do science and medicine. So I actually did a double degree in science and medicine. On the way through, I did honours in my science degree. So I did a research degree on the way through my medical degree in fetal renal physiology. Looking at fetal sheep. And then I took a year off and worked as a research assistant. And then I finished my medical degree. And at the end of that, I went, I'm never doing any more study ever again, which was incorrect. Because after a couple of years working as a doctor, I realised there was an awful lot I still don't know, and I still don't know a lot. So I did my fellowship. And at the beginning of my fellowship, my plan was to go and work in Africa, but I got married instead. And then when I finished my fellowship, started a PhD, always, essentially because it's really lovely to be able to answer questions, to have your own questions to answer, to be able to set questions that not have other people answer them for you. It's really nice to have a piece of knowledge that no one else has. That little slide there is I'm very excited about. And it's really nice to be able to then ask what's the next thing to ask. And I think it helps inform my medical practice, the kind of things that I do, the way I look at the people I'm looking after. It helps a lot in the kind of treatment that I give my patients.
Interesting. Any more questions? Okay. Well, please join with me in thanking the Peacekeeping group and thank you so much.